We go any further to have some introductions, because I can see some new faces in the room, so I think it might be useful if we all introduce ourselves. I'm Hazel Simmons, and I'm leader of the council, and I also chair Health and Wellbeing Board. So we'll go this way, Umi.
I'm Umi Ali. I'm a councillor for Hightown Ward, and I'm the portfolio holder for Children's Services, Health and Wellbeing.
Hi, I'm Bassett Mahmood. I'm portfolio holder for Adult Social Care.
Hello, good evening. My name is Azizul Ambia. I'm the Conservative Councillor.
Okay.
Bill Turner, Chair of Health Watch Luton.
Nisha Bradley, Director for Health Mental Health Services. Peter Malik, Portfolio Holder Public Health.
Bev Davis, Partnership and Engagement Manager for Beds Fire and Rescue.
Stephanie Simon, Chief Executive at Citizens Advice Luton.
Thanks, Steph. Behind you, those.
Christine Leeson, Public Health Manager, Luton Council.
Oh. Sorry, Nicola Ainsworth, Public Health Consultant.
Alaman McKeith, Information Intelligence Manager, Luton Council.
Hello, I'm Jill Britton. I'm the Director of Adult Social Care. Sally Cartwright, Director of Public Health.
Richard Underwood, Chair of the Health and Social Care Scrutiny Review Group.
And last but certainly not least, oh no, Robin.
Hello, I'm Robin Porter, and I've got the honour to be the Chief Exec for Luton Council.
Okay, so welcome everybody. Oh, I still didn't let you speak there.
That's right. Good evening, everybody. I made it literally by running. So I'm Nikki Pillane. I'm the Chief Primary Care Officer, but most importantly, but like Robin said, very privileged to be the Link Director for Luton.
So welcome everybody. I hope you enjoy this meeting. It seems a long while since we met before. So we've changed the format slightly, which I'll introduce in a minute, but let's deal with the apologies.
Thank you, Chair. We've had apologies from Mark Fowler, D. Raj Chibba, Felicity Cox, John Tizard, David Carter and Councillor Bridgen. Thank you.
Okay, thank you. We've got minutes from the 3rd of April. If anybody got any questions, I'm not going to go through them page by page. Has anybody got any issues they wish to raise from the minutes from April? Yes, Richard.
Chair, there's a typo on page 3 of the minutes. Second paragraph should be mortality rather than morality.
Okay, correction. Thank you. Yeah. Anything else? Okay. Can we approve them as a true record? Or is there somebody else? Okay. Right. We have no urgent business that's been brought to my attention for tonight's meeting. And we have changed the structure of the meeting around a bit tonight. And we've got some 4 information items and some items to take some decisions on. But we thought we'd look at some real serious challenging issues that we as a service group have to deal with, and we thought we'd have a discussion and perhaps come up with some ideas on the way forward. So we've got a review of residential care, and I'm going to ask Jill to start us off the debate here.
Lovely. Thank you. I'll just try and share my screen. There we go. Go. Let's get rid of that. Okay. Right, sorry. It's always some technical issues, isn't it? So I just thought prior to this discussion that I would just set the scene a bit about our local residential care market. It is primarily related to residential care, this briefing, because that's where we are in understanding all of our cost and demand, but there are some elements of nursing care in here, and obviously we commission both. This you will all know, it's just a very quick overview of Luton. We have, what's crucial here is that we do have a younger than average age population, which I know that you're aware of, but nevertheless, we still have needs for older people's care. Looking across the country, you'll see the ratio there of the residential care homes to nursing homes. Just to give you a bit of a picture, as I say, I'm not going to go into this, but it's just to give you that overview that you would expect to see more residential care homes than nursing currently. But whether that's something we want going forward is for debate, I think. And then in Luton, just having a look at our demand for adult social care, you can see there that we support around about 4,000 people a year. That number does fluctuate a little bit, but it's quite a significant amount. And that we also have 72% of our local registered care homes, that's nursing and residential, are rated as good or outstanding. A little bit of a caveat on that, there's currently 25 of such care homes. One of them has not been rated. 3 of them were rated in 2021 as required improvement and haven't been re-rated by the CQC, which they ought to have been by now. And then the 3 of them were rated as required improvement in 2023. So again, some of them are due or overdue a re-rating. So there's a bit of a time lag and not much we can do about that specific element, but we are working with those care homes. They were all put on improvement plans when they were originally rated as required improvement. And for the majority of them, they've moved off those plans and we think they're operating well. It's also just worth talking about the increased demand that we've had in Luton since we saw a significant decrease in 2021 due to COVID activity, the pandemic, with a disproportionate amount, obviously, of deaths, particularly in the older population due to COVID, but also a fear of coming into adult social care and particularly residential care due to the pandemic and all of the national press about the deaths in care homes, etc. But we've now more than recovered from that and are now seeing more than 1,500 contacts coming to us for asking support for adult social care than we were pre-pandemic levels. So we've not only gone back to, but we've now exceeding. So it's a very difficult demand-led service area. And you'll also see in there that it's about 1,600 older people that we're supporting. Now, most of those will live in their own homes in the community, but a number, as you will see, do live in residential care homes. This little graph just tells us a bit about that, the number of people kind of accessing care and support of the over 65 population. And what you will see there is that dramatic fall from the COVID era from 2021, as we previously discussed, but also a rise back up there to 2023. The other colours are projections. I'll come on to that in a moment. So you'll see at the end of last year, we were seeing that rise of people with occupying nursing or residential homes over who were over 65, but we hadn't in this case got back to pre-pandemic levels, so we are keeping that number as low as we possibly can. The 3 projections there are, one of them, the orange one in the middle there is just holding the rate going forward from last year. Projection 2 uses the average rate for the last 5 years, and you'll see how that's increasing. And then the projection 3 just looks at 2021 to 22 and 23 data, but because of that big dip, I think that is rather an unreliable projection for these purposes. We also know that, oh yeah, that's okay. I was going to read the bottom bit, but I've already said it in a different way. And then if we look at comparative slide, looking at the costs of that residential and there's just residential care actually for this one, you'll see that the costs are also rising. And in all three of the projections, even with that dip, we would expect to see increasing costs because the costs have risen slightly disproportionately to the number of people. And for a range of factors, of course, we know that we've had high energy costs, inflation. Every time the national living wage increases, then the costs of our care provision increases. But we also know that there is some relationship between demand and supply. So if you have more demand and less supply, then the market is able to ask for a higher price as well. And we'll come on to that in a little while. So moving on, if we split those cohorts of over 65s by the type of primary care need, you'll see by far the highest, and that's the green line at the top, are for people with a physical disability. And then we've got mental health support next in the middle, and learning disability at the bottom. There is some slight problem with this data. It's very hot off the press, and we just need to I wanted to share it with you, but we do need to re-look at it because we are not describing there our people with memory and cognitive needs, and the percentages don't quite add up to 100%. So I'm not sure what it's a percentage of exactly. So we'll do some more work on that. But a lot of people with dementia, essentially memory and cognitive support needs, will probably also be showing in the mental health bracket because we think there's a bit of quite a lot of miscoding. But just to give you an idea of the types of need that we're seeing coming forward. And within that increased demand, we're also seeing increased complexity, particularly demand for specialist dementia care for those with very complex needs and challenging behaviour, reflecting the longer life expectancy that we're seeing across the country, but also in Luton, that people are then more likely to have dementia. There's an increasing need for early onset dementia. Now, that is a specific term which means having dementia before you're 65, which often needs specific highly intensive care because it tends to have more rapid progression. And there are around 200 different types of dementia, and the most rarest forms are the ones that tend to happen in the early onset cohort. So you can see that management of those individuals might be different from the more common types such as Alzheimer's. More people are also generally experiencing multiple long-term conditions. So this ageing population increasingly presents with complex overlapping health issues and different types of care and support needed. And we're also seeing an increased number of people with a forensic history. So people who've previously been in prison and coming to the end of their sentences and coming out of prison as elderly people, but where the public needs to be protected from them for a range of different reasons. And we're also seeing our cohort of people with learning disabilities over the age of 65 growing. And of course, that brings another different set of complex health and care needs to really work with and understand. In terms of demand, CITFA, which is a national organisation looking at finance and management of council budgets, in their report on managing rising demand in adults and children's social care, highlighted how councils can use their demographics and demand modelling to influence and inform sufficiency, which is what we're trying to do in those previous slides and other work that's ongoing. But they also recommend switching the focus to short-term residential care to prevent the overuse of long-term services. And for short-term care, what we mean by that is to manage acute episodes of care. For example, an episode of delirium or a fracture, as step down from hospitals, and respite step up care, and focusing not on permanent admission, where community interventions, that's people help and support people in their own homes, are significantly higher quality and ability to manage care at home now that our health colleagues are managing that virtual ward setting, etc. So ONS data estimates a 3.1 rise in care home residents between 22 and 23. However, this reflected an occupancy level of only 80% at CQC registered capacity, and during the same period, a corresponding reduction in total bed capacity. So from 461,000 down to 460. Sorry, that says it's gone up, but I will look at that again. 37% of people in care homes are classified as self-funders, with 63% state-funded. And overall, there's been an increase in 9.2% in self-funders in that period, 22 to 23. So on the whole, most care homes have between 20 and 29% of self-funders. And the average for the east of England, though, is a self-funded proportion of 40%, with the highest in the country being in the southeast or the southwest of England. The size of home also influences the proportion of self-funders, with those with 1 to 9 beds have the fewest, and those with 60 or more beds have the greatest. And that is something that will be reflected in Luton, as you'll see later. So in terms of supply, industry experts have forecast a decline in capacity overall up until December 24, and the national shortfall in supply levels of market of standard beds we think will increase from 57,000 to 64,000 by December. So definitely a shrinking market. So one, if we don't manage it well, we will struggle to be able to access the right kind of support. The east of England has lost some 15 homes. There are currently 25 registered care homes in Luton, 18 of which are registered for elderly care. And we in Luton have lost, since I've been here, 2 homes and another one in a year previous to me being here. So this is something that's really real and happening here. So in Luton, over 831 beds are in the larger category of homes of 60 plus beds, which we know will attract more self-funders. But there is also currently a large proportion of people living in our extra care provision with low levels of needs. And I'm raising that for a reason. Perhaps we've been inclined in Luton to put people in residential care earlier than they needed to be, and perhaps we could be supporting those with higher needs in some of our extra care provision. I'm not going to read all these out, but you'll be able to see these, and I'm happy to share these after the event. But nursing and residential home capacity in Luton is not so this is a current snapshot. So you can see there is lots of beds out there, lots of usage of beds. But in terms of if we're looking for occupancy this week, as of October, there is only 3 nursing beds available to Luton Council and only 16 residential beds. And a lot of the reason for that is a number of those homes you will see will not accept the local authority rates. So they will only take self-funders or residents from other local authorities who will pay more than us. So it's quite a difficult situation that we're in. This will tell you a little bit about why. This is what we set as our average weekly rates. So it's what our standard rate is that gets published on our websites. And you can see that Luton there is quite significantly lower than in the rates that we're able to pay than Bedsborough and Central Beds, which means that some care homes will want to attract those residents and not ours. So I've just set a few questions there just to get the ball rolling, but it's up to you, Hazel, what you want to ask and how you want to structure the conversation. But I thought that could help us get going.
But members may already have questions of their own if you've got.
Yeah.
But there are a set of questions out there. Do you want us to go down one at a time, Jill? Would that be better? Yeah.
However you want to do it.
How can we encourage more loyalty to the council for our care needs? Are you talking from the individual's perspective or from the organisations that are here?
Oh, definitely from the organisations. So how can we get the care homes, I suppose, to be, it's just thinking about these ideas. If we want to secure better quality and local care provision for our residents in Luton, which I'm sure we all do want to, then these are the kind of questions we need to ask ourselves about thinking about what a new model of care might look like. Because currently we go out and we look for each bed on an individual basis. And I don't think that particularly helps sustain our market.
Are the organisations here? No? Yeah.
I suppose my first question, and it's as much to myself as to everyone else, but on that question about loyalty, is that we've got a great workforce in our Luton population, and I'm certainly thinking about how we could possibly do some generic training, accessing, and I know it's been picked up in other areas, but you almost have a passport, and so I'm thinking, is there something about the workforce that there's got to be something in it for those organisations of getting some of that loyalty? I'm also thinking of some of those areas where we think about the community voluntary sector, because isolation is quite an issue for residents in nursing and residential homes, and it's a fact because they're all now single rooms, and having an 89-year-old mum and with some of her friends, I know they're really lonely. So there is something about how we could engage as a council and as a system and doing some of that in-reaching. Just some ideas.
Well, I would agree. I think they're really useful things. I suppose I totally agree that there's lots of things that we can do, and I suppose I've set this up so we can all have a different rather than a Q&A we normally do.
Yeah, just 2 points of context for us all to just reflect on. The first is at a national level, local authority budgets are moving to a point where circa 80% of the budget is spent on social care. And if you think about all of the services, the 730 different services that we are providing to our 231,000 residents, 80% leaves very, very little for the other services, which are all important for residents. And then the second piece of local context is I'm just looking at our unyet published Q2 financial position, and the overspend that we're facing at the moment for adult social care has gone from £2.6 million at the end of Q1 to £6.7 million at the end of Q2. Those are the types of figures that have got the potential to be breaking the organisation.
Thanks, Nikki. I completely agree with what you were saying. I wonder how much more we can use the voluntary and community sector in terms of those care needs that are sort of, you mentioned earlier about less than 6 hours or so, where they're not using a lot, and whether we can optimise that. Ideally, we shouldn't have to, but we have great voluntary and community organisations that can. But I'd like to know a bit more about the discussions that we've had with health, really, because personally, I think a lot of this stuff, it's an issue that's affecting both the NHS and social care. It's causing delayed discharge, the fact that we don't have spaces in residential homes and stuff like that, and what sort of conversations are being had there, and where we can get more input from from health and the NHS in these areas.
Jill?
I can answer that a bit if you want. I know I'm not health, but I can tell you what our relationships are. So on the whole, I think trying to access residential care generally doesn't delay hospital discharge. There are some cases with this high complexity that can do. In fact, actually, it's more often the kind of care, the intermediate care that health themselves are supplying that has the blockages within it in terms of that bedded intermediate care. But we really ought to be having conversations about why we're using so much bedded intermediate care. We should be providing almost all of that in people's home settings, I think, these days. And in terms of that, the voluntary sector for people with low levels of care, I totally agree. I think there is more that we can do. And again, it's about kind of introducing people to those things before they're in receipt of a care and support, where they will get more social connection and be less isolated, which will really help them in their general well-being as well. But it also worries me that if people with such low levels of care are in our 24-hour staffed extra care, why are they living there, and how did that get through our allocation policy within the council? Because they don't need that 24-hour care. If they're having less than an hour a day of care, then it just doesn't make sense that in some of our schemes more than 50% of the people there are having such low level care. So I do think that's something we need as a council to really be thinking about.
Are you talking about sheltered accommodation?
No.
So actual extra care?
Actual extra care.
Can I ask then, how is that reviewed? Whose responsibility is to review that? Is it sort of packages, and is it our social work team?
So it came about when we were going out to re-procure our externally provided extra care, and I asked for that assessment to be done. I don't think anyone had really done it before, so it came up through there. But I think it's more about how adult social care and housing work together to kind of change our allocation policy so that we're not accepting people with such low care needs. I think, in all fairness, I don't know, but my guess is that it's probably because of the general housing crisis within Luton, that if you've got somewhere for someone to stay, then people are being housed. But it's really not the best use of that resource because of we could be delivering, really very intense care there and not using the much more expensive residential care. And so our model needs redressing, I think.
So are we working on that now?
We are working on it, but it's, that will need policy change and various things. So it will take time to come through, but we have started that work, yeah.
Okay. Did you come back in? Yeah, no. For me, the question that struck me was that there's only 3 nursing beds in the whole of Luton.
So what I mean by that, there's only 3 currently vacant. As of
vacant, yeah.
Vacant.
But say you had 5 people that you needed to, what do you then do?
So, well, it would be quite unusual to get 5 new admissions in a week, firstly. But if that was the case, then that's where we have to start looking outside of boroughs and working outside of Luton with our neighbouring boroughs to see to get placements.
Do we have a situation where people aren't necessarily getting the nursing care they should get because we haven't got the beds to put them in?
No, because they would be in hospital if that was the case, I think.
Okay. That's it.
Thanks, Jill. I think our hospital discharge is one of our strengths, if I'm not mistaken, from the work that we've... Can you hear me now? Yeah, so I was saying our hospital discharge is one of our strengths from our self-assessment. Always we can do better, but it's one of our... I don't think there's too much of a problem with our hospital discharge. But on the fabric of buildings, without getting into specifics on need to knows, but is it more of a problem with the smaller ones, and is there an expectation among some of them that we can let this fall into disrepair, and if we're struggling, we can go cap in hand to the council, and then they will help us. Or what's the incentive for them? What incentive are we providing on making sure that that doesn't happen? Because you get complaints from residents.
Yeah, I mean, it's very difficult. They can't come to us. We won't fund it because within our rate, they're expected to be paying towards that upkeep of their property. But we do know that, and that's probably why a number of the care homes that have closed in the borough have closed. It's because they're no longer fit for purpose because of the structure of the building. And we can see that a number of others that are struggling in a similar way. And we had another care home which closed, which reopened since I came here, closed to have a total refurbishment, which is brilliant. But since they've reopened, then they said, well, we've spent all this money now, so we want these rates that are, over £1,000 a week. So it hasn't really helped us because we can only use that care home for self-funders. And of course, self-funders money will run out at some point. And then we were in an unenviable position of thinking, well, do we move that resident who's now settled there and happy and well, hopefully, or do we as a council then have to pick up that very high cost? So we're kind of stuck. And what I think one of the reasons is we don't really have strong partnerships with these organisations where we share that financial risk and we share that responsibility. It's all they've got to fill their beds and they want to obviously have the security of income, and they're more likely to do that because remember that some of them have got only 80% occupancy. If you go back to the thing, then they're going to need those beds to be paid at a higher rate to cover all of their costs. So I think there's more that we can do in our strategic commissioning and work differently with those care homes, but also work differently as all of Bedfordshire together, to really be buying things together and uniting on that front, not just with our local authorities, but also with the ICB for nursing beds, so that we're not outpaying one another and we come to an arrangement where we have a price that's much more similar. But that will take, as you can see, those prices are quite different. So that's going to take a bit of negotiation and work and maybe, an iterative process to get there.
And are we working on that?
We are working on that. We have started to work on that. And in fact, it's one of our transformation priorities.
Okay. The question that interested me was how can we rebalance the supply of nursing provision? What exactly are you saying? There's not enough nursing provision? Yes.
Yeah, there's not enough nursing provision, but there's quite a lot of residential. And if we move to our model of using residential less or just for short-term places, we really want to be encouraging residential providers to make their care homes nursing. But of course, they need a different skill set within that. And they need more help from healthcare, our health partners, to be able to do that as well. And I think we need to go to them with, an incentive and working a partnership journey to get them to that place as to making that change in their registration. And so that's not an easy thing. And attracting nurses to work in care homes is particularly difficult.
Okay. I suppose there's not the payment. It's not the pay levels. Honestly. Yeah.
And I know, Jill, you're working through this, but and if they've all been exhausted, these suggestions, but we have talked, and I know that the Acute Trust, I know we haven't got anyone here tonight, but about some rotational roles that really to try and make it an interesting, career path. And again, I think that is something that if we collectively look at our residents, so not the ICBs, not the acute, we look at our residents with your data. I'll be honest, I was completely unaware of people coming out of prisons or whatever, and where you needed some of those extra needs. So almost if it's worked in the way that what is the totality, and what is the difference? So what are the extra needs to different cohorts? And I just think, Robin, there is something about bringing that into that system, that we have to have some levelling of costs. And as you quite rightly say, the other part is that we know, and we're working on it, and Councillor Mahmood, you were saying about we're doing well with the discharge. If we look at the total, I mean, the health is 2.4 billion, that's right, isn't it? 2.4 billion. And we know that we spend a lot of funding in acute settings. So, I mean, the Darcy report's helpful. You can see over the last 10 years, more's gone into acutes and less gone in community in primary. If we had that mature conversation, but it would need, people like Robin holding the torch at showing the numbers, because otherwise, as you quite rightly say, Robin, we're going to collapse. What's the point of one part of the system collapsing because we've got the A&E? So, I mean, we all know what the impact is. I suppose it's to try and dissect, or almost put into granular bits what we need other partners to do.
So what role can the Health and Wellbeing Board play in this? Anybody got any ideas about how we can be forceful in helping on that journey of getting people together? Did you have your hand up? Sorry, Amelia.
I was going to ask something else, but yeah, I mean, what do we? Thanks, Nick. I completely agree. I think we need to look more about what we can do as a partnership. I guess the board has all of our partners here.
Yeah.
I did want to ask something different, if that's okay. In terms of having people, when people are, or what's the word, like taking care of their own elderly relatives, particularly in a population like Luton, where we might see quite a bit of that. How much are we looking at how costs could be saved by doing more supporting people to keep people in their homes in old age with support from family, so that can reduce the strain on residential nursing?
Yeah, so we're absolutely doing that, and that's bread and butter of what we do. And we've just relaunched our kind of carers strategy and implementation plan only a couple of months ago. So we will work with that. I think for me, I would like to see, more conversations with our health colleagues about how they're working their step up and step down virtual wards, and us working social care in partnership with that. I think they're still quite isolated. So they're doing that, delivering that really intense healthcare that families can't do, intravenous medication, all of that kind of thing. But I don't think we've got kind of social care working alongside it. So where is our home care providers, etc., doing that and working alongside district nurses? I think it's still a little bit siloed, and there's more we can do in that space.
So there's more we could do to get health and
social care delivery together. Yeah, definitely.
Okay. So yes, Sally.
Thank you. I was just thinking about that point, and where do we embed that in our strategic plans to make sure that that's written down as a commitment? Because I'm about to do the next year on refresh of the population wellbeing strategy, which doesn't at the moment articulate that in that kind of detail. It talks about the TOM, I think, the adult social care target operating model, and it talks about lots of things, but it doesn't make an explicit reference to this point. And if we're doing an annual review now, it might be a useful opportunity to kind of pin down what we're committing to in that. Or if it sits somewhere else, it's the question.
Doesn't it come out in our joint strategic needs assessment? Don't we then note that, and the needs of our community come up? Don't we then kind of take it from there?
Yes, so we're seeing that as an item shortly. Without preempting that item, I don't think it goes into this level of detail in that. But yes, the joint strategic needs assessment would set this is the population need, and then we all say, what are we going to do about it and take forward in our strategies. That's the principle of the flow.
Okay. Is there anybody else? Yes, by all means.
I was just wondering if there are any case studies of other areas who are facing exactly the same problem as us and how they're addressing it. If there's anything useful we could learn from them.
Yeah, I mean, I don't have any to hand, but I can tell you that kind of one of the biggest thing is that move to kind of really only using residential care, not nursing care. If people get to the point they need 24-hour nursing, they need 24-hour nursing, and you're not going to get away from that, and you can't delay that, when people are really poorly to that extent. But in terms of not using so much of that residential care and using extra care, and allowing people to live still in their own homes it is really powerful, and there's lots of examples of that across the country, and I think also in terms of the things that you were talking about, reducing that social isolation within residential, there's lots of really good examples of that, and intergenerational work, bringing the local primary school kids and all kinds of things that is really supportive and mutually beneficial. So there's loads of examples. I think it's called the World Health Economics website, is really good for looking at things like that that's happening across the place. Yeah.
That's it.
Thanks, Jill. Just very quickly on more loyalty to the council. Just as general, I mean, I was glad you mentioned procuring with other local authorities to try and keep our costs down. But one of the things, just as by way of an example, as a case study, I think. So I always draw back to Wigan, who've done really well on adult social care, and we're fortunate enough to have someone formerly from Luton who's kind of mentoring me a bit on adult social care. Then one of the things they've had is an ethical procurement charter and an ethical framework on really, commitment to community wealth building, including radical redesign of home care around a neighbourhood model, and making sure that because our local provider market isn't I don't think as diverse as it could be. And I was just wondering if kind of an ethical procurement charter is one of the ways we could look at building more loyalty to work with them.
Yeah, definitely. I think both ethical procurement and also kind of like how we drive up social value within our procurement as well, and what we're asking. And I think that councils tend to be very good at that if they're doing procurement of like building works or whatever, because it's easy to say, well, you'll employ this many apprentices or whatever. But it needs to be quite different, I think, in the social care market. But there are lots of good examples of how we could drive up that social value. But also, if we were supporting, as Nikki was saying, if we're supporting those organisations with, you might not get the full rate for us the same as a self-funder from us, but we'll give you all these things in kind through our partnership, such as, the dementia care service that Michelle's team delivers, or the rotation of staff, or a joint bank with the nurses in the ICB. These are the kind of things that we would be able potentially to secure a kind of quid pro quo and in payment in kind. There's lots of creative things I think that we could be doing.
Anybody else? Yeah, sorry, Nikki.
I just wonder, because there's some positive things, because I think at the moment, so some of the digital work has been very supportive, and I think most have now got Wi-Fi in. So I just think there is something about how we're capitalising, because sometimes it can feel a bit doom and gloom. We haven't got anybody here from the community services tonight, have we? Has anyone? Am I missing anybody?
No.
Oh, so
I'm not Anita there, but Anita has been emailing me to trying to get on UMS team.
Because I just think
start to send her apologies.
Because I just think there is something about, we don't know what we don't know, some of us, and I don't know what more, but I absolutely, for me, it is the community, physical and mental health together. Because I know when we've done some of this analysis before, we have mentioned carers, and I know it's always in the back of everyone's minds, but often it is about carers, and sometimes it can be that just collapsing, and then everything happens in a bit more urgent emergency, and you tend to, that assessment isn't quite as balanced. So I genuinely think there is something that we all need to lean in to see the urgency of this. I mean, it does feel a bit burning platform. I also, Robin, I was absolutely bowled by the 6.7 in Q2. So in one quarter from, that has progressed. So my concern is it's not being dramatic. It's catastrophic, isn't it? So there is something, other people need to lean in, and some of that may be us collectively about managing expectations. Sometimes it's crisis where you do make that transformation. So I'm absolutely willing and have, but I don't know what I can do to help at the moment is how I'm feeling.
No, and I'm not sure at the moment what role we as a Health and Wellbeing Board can play, but I do think it's because of the urgency of it, we need to be involved in pushing this forward.
If I could just talk, so one of the things that I think, Nikki, you could help us with is I've had conversations several times with people from the ICB about potentially having a joint procurement, care placement offer. So looking for those individual places, because that would really help. Because if an organisation didn't know it was, because I'll be honest with you, across the country, residential care, nursing care providers think of health as a soft touch to get higher amounts of money. Now, if they didn't know, if it was just Luton or just Bedfordshire or whatever coming across to get those beds, then they wouldn't push the price up for the ICB, which would work. But it would also mean that we were starting to buy together on a similar platform. And similarly, I do think that we need to look at our costs across the board. We didn't have the costs up there because I'm not sure that I've got the costs because they don't have to publish it. But how much the ICB are paying for nursing care, and I think it's about us all four partners coming together. And if we could organise, some kind of summit to look at some of these things, I think that is something Health and Wellbeing Board could help.
That's something we could work with you on. I think that's a very good way forward. Yeah. Across BLMK and everybody sit down and look at this in more detail. Is there anybody else? Yes, Umi.
I think that's kind of what I was alluding to at the start when I was talking about working with health, and I think it's interesting that we're not already doing that, but I think that's an issue across all sectors where we're just not working well together. But how, moving forward, are we going to make sure this isn't just something we're discussing in a meeting and it's actually going to happen? Do we need to have it written down somewhere? Do we need commitments from the room? I think that's the important thing, because I feel like it's something that we talk about all the time, working together better, not having silos, and then it's the same issue each time. And obviously some of this is a national issue with we need national government to help us, but it'd be good to know how we're going to actually make action from this.
Yes, Nikki.
I'm just thinking about supporting Councillor Malik because you chair the partnership forum, and it could be, if people are in agreement, which I think is what Hazel's alluding to, is that this is something that this Health and Wellbeing Board want taken to that forum, because that is the place where it is the system convener, and it would be, if you're in support, us doing the legwork, but the mandate would come from this board.
Yeah. Thank you, Hazel. I think I've had the conversation with Bassett already to raise it on the partnership in terms of the issues that are being talked about tonight. But I think there still is there's a second element that Umi raised as well. There's the bit around having BLMK working together and having that same level playing field in terms of what we're paying for collectively. But then there's the other element around carers and making sure that we can keep residents in their homes. I just feel that when I've worked with residents, it was quite easy. The rest of the family's there, but it was easy to send them off to residential home or nursing home, etc. Because if we're able to support the carers and value our carers, some of them that are unpaid, it's not just about having a document where we're really looking at the carers and it's Carers Week and we talk about it and that's it. And I think we hear, and then again it comes to what do our neighbours actually, how are their carers? I know some of them in Bedford are better than we are in Luton. So how is it that we can bring them up to the same standards in terms of how we value our carers? Because I think it's all together. It's those people that are living longer with more health conditions. How can we support them to being in their own homes and adapting that? And that is through housing as well. That's collective. It's not just health. It's about how are they, do they need adaptations? How quick are we able to do those for them, to remain them in their home? You know, is that why they need to move out? Do they not have the right care? How can we support their carers better and value their carers? Because, you know, I think that is really, really key, because if they're not motivated and they feel that they're not valued, you know, how much more can they put in? Because some of these carers are drained out over the year. And when they've got more needs to tackle that, it's their health that deteriorates at that point when somebody goes into hospital and comes back out again. So I think I will definitely fully support that. I've had a chat with Bassett already that I'll be taking that up on my next partnership, but really good with the Health and Wellbeing Board supporting me in trying to do that moving forward. Thank you.
Thank you for that. I'm happy to take that forward with you as well. I'm going to call it to a close now, because I don't think we can move any further than we have, but it's got us moving on a direction as well. And maybe an idea of a summit is a good one to get the adult care up the agenda a bit, because I think perhaps it doesn't always come up in people's minds either. So thank you very much for the questions and the work, Jill. Thank you. And thank you everybody for contributing. I'm going to move now on to the performance management items. And the first one is Luton 2040 measures and partnership governance. And I see Jane is at the back there. So I'm assuming you're going to lead on this, Jane.
Hello, everybody. If you can just give me one moment while I get the slides up, and then I will be with you because I've got to join the meeting.
This one's on.
Okay, thank you for bearing with me. Hello, everyone. My name is Jane Malcolm, and I head up the 2040 team. I think I know most of you. We've got an incredibly ambitious vision, as you know, for Luton 2040, which is to end poverty across the town. We've only got 16 years. And in order for us to be able to do that, we need to become more targeted in our approach. We've got some fantastic priorities, of which health and wellbeing is one of those core priorities. But we now need to move to being much more specific about what we want to deliver and what we need to deliver over the next 16 years in order to be able to deliver our ambition. And the paper that you have been sent in advance outlines what we need to do to be able to achieve that more targeted approach. So firstly, that is around setting really clear outcomes and measures, of which you were given a spreadsheet with those on. Because this is an iterative process and we're working with a whole system, there have been changes since we even sent it to you, which I will outline briefly to you. We had this conversation only last week with Place Board, which we had some really good feedback from. So thank you to those who were able to help with that. So that's the first thing, is agreeing what are the measures, what are our long-term measures for tracking change. Once we've done that, we'll go back and put some targets in around those measures, and that will give us a roadmap to 2040. What are the things that we need to achieve along the next 16 years to be able to reach our ambition? And then the second thing we need to do is review our governance in terms of who is responsible for delivering on those measures, who is actually going to take the lead and say, right, we're going to make sure that we're changing the dial. So I'm going to just really briefly, because this is quite complex stuff. I've just gone through this. This is what we need to do, and what I need from health and wellbeing today is to agree our shared measures based on any feedback you have. These need to be shared measures that we all think, yeah, this is the dials that we need to change if we're going to reach our ambition. and agree to explore which partnership group is responsible for each measure. I don't think we'll be able to decide that today, but just to agree that we're going to explore that, and we'll come back at some point to say we think it would be these measures that Health and Wellbeing Board could take responsibility for. And then finally, so I'm going to highlight the bits in pink that we need to do today. Elect people to join the Luton 2040 Partnership Group, which I'll talk a little bit more about in a moment. We have lots of measures, don't we, across our system? We like measures because they help us be targeted. So I just wanted to do this little diagram, which BI helped put together, just to see, give you a bit of context of what we're talking about here. So right at the top of the pyramid, we've got our 2040 measures, which is what we're talking about today, which are those overarching long-term measures, which we're trying to change the dial on. Underneath that, we might have our system level strategy measures. So Sally mentioned the population wellbeing strategy, of which you all know you've got measures that you're heading towards. They'll all contribute towards the 2040 measures. And then finally, we'll obviously have our individual organisation measures. And the hope is that each of our organisations will have measures that really do contribute to that system-wide measure. And we've just gone through, as a council, a mapping exercise to do that with our own corporate measures. So there's a real synergy between what we're doing in the council and how that contributes to 2040. And for other organisations that are here, we'd be delighted if you think about doing the same. And then in terms of ownership, the diagram that you had in your pack has slightly developed just to show that there is real synergy between the different boards. We've identified about 10 different groups, 10, 11 different groups that potentially could take responsibility for one or more of the 2040 measures. And in the middle there, you've got the Luton 2040 Partnership, which is a new group that we're looking to set up with an aim of bringing the work of all those different groups together with a specific, very targeted focus around how do we reduce the number of people having to live in poverty in the town. So these are the measures, and you had them in spreadsheet form. We've made them look prettier, which I think really helps. But the aim of this is really just to show what are the top 6 measures for 2040. So if we could only ever have 6, these would be the top ones we'd have. And you'll see that the very, very top one is the number of people, the percentage of people living below the basic standards of living, which is all in purple there. All of the measures are here, and you're not going to be able to read those because they're teeny tiny, but I can send them to you. They are in spreadsheet form, but I can give them to you in these wheels as well. And then these are the health measures, which we're looking to change the dial on. And I think the one that has changed from your pack is smoking prevalence, which is giving us the dial on whether residents are able to live a healthy lifestyle, and that's instead of physical activity. So that was the advice that we've been given. Other than that, they should all be the same. Oh, I've got a black screen. Not sure why I've got a black screen. Here we go. So what I need today from Health and Wellbeing is to agree, have your agreement that you're happy with those measures, subject to any changes you might want to discuss, to agree that we will explore that partnership, which partnership group is responsible. And finally, it would be fantastic if the group could elect one person to attend the 2040 partnership alongside Hazel as the group's chair.
Okay. Comments on anything that's been raised by Jane? Are we happy to agree the shared measures that we've got before us? Or is that a yes? Yeah. Are you assuming that we have to agree all of the measures you've got in front, or are we talking about the healthy life expectancy or something like that? Is that what you're asking us to agree?
I'm asking you to agree that you're happy with all of them as a health and wellbeing board. So there's 39 measures.
Yeah. So I'm assuming, as nobody's said no, that these are terrible, that you're happy to go with the ones that have been selected. Am I correct, or? Yeah? Okay, agree to explore which partnership group is responsible for each measure. So you're not asking for an answer to that tonight, I'm assuming?
No, just that you're happy to put it on your forward plan.
Yeah, that's what I was going to ask. What did you mean? So do you mean that little pie chart thing that you had, not pie, whatever it is, the Venn diagram that you had of all the, as in you want to have different boards responsible for specific measures of those 39 measures. And if you don't find an area, who's responsible, if that makes sense? So if you don't find, are you hoping to allocate all 39 measures? What if you don't find? Does that make sense, what I'm trying to say?
Yes, absolutely. We'll want to allocate all 39. And I think it'll be really interesting if we find that there is a measure that doesn't sit anywhere, and we'll have to explore what we do with that. Hopefully the partnership group will be able to suck up any measures that don't sit anywhere. I think another challenge we might have is, so there are, for example, there's 4 key health groups. So who's taking responsibility for each of the measures across those 4 groups, and how do they relate to each other? And I think that might be more of the challenge that we have when we're trying to identify where the measures sit.
And what would they be responsible for? The delivery, or like what exactly, apart from discussing it?
Thank you. That's a really helpful question. It's for overseeing progress. So we will provide a report more than annually if we can, so that you can oversee whether progress is happening in those areas, and where there isn't, collectively take action to improve the situation.
Kind of like scrutinizing.
Be scrutinizing and also planning. So identifying where there are gaps in plans, identifying where there needs to be development of plans so that things can change and improve.
So we've agreed that the 39, because nobody's said anything against any of them. I'm not sure, agree to explore. I think we're going to have to look at that a bit more, to be honest, who's responsible for each of the measures. I think that's, yeah, unless you've got an answer to this.
The one thing I think for me, it needs to be non-bureaucratic. So, for example, the place board reports into here. So I think we need to make sure, when you were saying about represent, is that where this fits into your 2040 partnership, and not, otherwise we could be doing a lot of reports to a lot of meetings. So I think we need to be really clear. For me, I need to be clear if it's about actual delivery, or is it a forum that's actually helping to do something about it if delivery isn't happening? Does that make sense? It's almost tactical delivery.
Yes, Sally.
Yeah, I was thinking along similar lines. So there's actually 3 boards that in theory are sub boards of this. So there's the Place Board, Children's Trust Board, and the Health Equity Town Partnership, which are all delivery boards of the population wellbeing strategy. And it is slightly confusing because the Children's Trust Board then has ownership of a key priority of 2040 in its own right as well, which is fine. It just adds a little layer that we need to be aware of. But I think though that wheel of those health measures, they should probably, I think, but we probably need to bring back what that looks like, be allocated to those sub boards, to then this board have that oversight of how they are being delivered through those boards, I think. But maybe we need to go away and work out what that might look like to bring back to a forward plan, a proposal, because otherwise it feels a bit nebulous, doesn't it, to say how do we get to that point? So maybe that's the action, then put it on the forward plan to discuss.
And that perhaps needs to be done outside of this meeting, I think, is what you're saying. Yeah.
Yeah.
Okay. Yeah. Anybody else? Yes.
Thank you, Chair. You set up 5 priorities. So I'm trying to referring page number 17, 6.4, where you mentioned the child-friendly town, and also mention about health inequalities. What we seeing is across the Luton, we don't have the playground facilities or outdoor activities are very limited, and also they are not well maintained. So because I can refer, especially in my ward, there's a couple of playground is not in proper condition. The thing is, how are you going to achieve this your objective where the lack of facilities because of the funding or because of the mismanagement? And I would like to address here is our chief executive officer about child-friendly town where we have a limited resource of playing activities, and whatever we have, they are not well maintained and well equipped. Thank you.
Robin?
Yeah, I would get a little grumpy with the term mismanagement. Luton Council's gone from receiving £120 million a year in grant funding from the government every single year to £14 million. So we've had to make some quite hard decisions over the last 14 years. And those decisions have not been nice decisions, and not decisions that we've wanted to make, but we've just talked about the fact that a substantial proportion of our budget goes on social care, leaving very little for other investments and other sources. But the leader has asked officers to look at what can be done over the medium term, and we're coming back to council with a plan.
Okay. Rumi, did you want to speak? No. Okay. So I think probably if we agree that the partnership group, the place board, perhaps looks at the measures and thinks about where it's best to take from there, would that be a sensible way forward? Do you think?
Yeah, I think so. I think there's a few people that we can put our heads together and think about what that might look like. Yeah.
Okay. We've got to go somewhere with it.
Yeah,
so
and bring
that
something
seems
back
me
to here.
Be a sensible way. And so the final decision is to elect somebody else to sit alongside me. Umi? Okay, that was good. Anybody else? Make sure there's no. Okay, great. We'll leave them. Thank you. Was there anything else you need from us this evening, Jane?
That's everything. Thank you ever so much.
Thank you. Thank you very much for coming along this evening. Right, update of the Joint Strategic Needs Assessment overview, and I think that's probably Sally doing that, is it?
Taking away the action, yes, that's fine.
Yeah.
So yes, so JSNA, sorry, I was slightly distracted. I thought we were still on the last item, apologies. Yes, so the JSNA, Alamin's going to talk to, but I think it's really timely from the other conversations around how it all fits together. And I think I mentioned previously the population wellbeing strategy is about to do its what we achieved in the last year review, and then what are we going to do going forward? And this JSNA will really feed into those next steps as well. So in that context, I think it's really helpful.
Thanks, Sally. Good evening, everyone. I'm Alamin McKeith, Intelligence Manager at the Council, and I'm here to talk through the update of the JSNA overview. Pertaining to item 8A in your packs is the full document, and then 8B is the executive summary sitting alongside it, which I will bring up on the screen in a few moments just to go through some of the exceptions of the report. The JSNA is something we need to do in order to assess the health and wellbeing needs of the population. It's done in a number of different ways. There are a number of different reports that we produce. The JSNA overview is one. We have a number of topic-specific needs assessments published on the Council's website in the Luton Observatory section. And also we have tools such as the Social Progress Index and our Community Data Hub Luton Insights, which gives you and anyone else interested to know what the needs are, health and social care needs, but also beyond that of the population in Luton. There's very good data quality information available. Onto the JSNA overview itself. It's a document that the current design of the document started last year. It's a document where we set out more than 100 indicators across the spectrum of life in the town, aligned to the Luton 2040 priorities and measures within that. It is obviously heavily focused on health and social care needs or health and well-being, but it does go beyond that, what we call wider determinants. So it includes things pertaining to the environment, education outcomes, housing provision, and so on. The document itself is at Luton level, so the averages that we have there, or the outcomes, are at Luton level. And there are other documents and reports that we have that go into ward and specific neighbourhoods, but we haven't done it for the Luton, for the JSNA overview. In terms of the document itself, like I said, there's 106 indicators. Most of the indicators are taken from reputable websites, government websites, ONS, so publicly available information, ONS, Public Health England's fingertips. So the data quality is really top level information there. The overview is a factual document, and what I mean by that, although it's under the performance section of the agenda, it's not a performance report in the sense that we're trying to answer the why things are the way they are and what we're going to do about them. So it's not a performance report in that sense. It's a presentation of facts as we find them for each of the 106 indicators. What we have done, though, we put benchmarking information in there to give you some context of how we are performing against our England averages, East of England averages, and our statistical neighbours where we have that information. Okay, so I think what I'll do then, I'll share my screen and I'll just go through some of the outliers, or the by exception, rather. This full presentation is in your packs, but I'm just going to jump onto page 9 of it. So in terms of health, or areas of concerns, what I've done here, I've extracted the criteria I've used to extract these are where we're getting worse in terms of the trend. So year on year, things are going the wrong way, and we're performing worse against our benchmarks. And where that criteria is met, I've pulled them out for you, and I'll just quickly go through them. So health ones first, and then the wider determinants. So in terms of, so this is obviously, as Sally mentioned, it's aligned also to the health and wellbeing strategy. So in terms of starting well, rates of infant and child mortality is significantly higher against both regional and national averages. Proportion of babies who are born with a low birth weight is also significantly higher than national and regional averages. There's a problem. There's an issue with also vaccination rates. Percentage of 5-year-olds in Luton experiencing visually obvious dental decay is higher than both national and regional rates. Hospital admissions for substance misuse for those aged 15 to 24 significantly higher. And then children in year 6, so 10 to 11 years old, classified as overweight or obese, is also significantly higher than our benchmarks. In terms of living well, this is the next phase of life. So younger adults, those currently being physically active is also significantly lower than regional averages. We have higher prevalence of diabetes in the age group, and smoking rates are higher for Luton compared to both England and Eastern averages. The older segment, screening for breast cancer and cervical cancer for women has dropped over a sustained period of time and is lower than the England and Eastern averages. And the screening for bowel cancer is also lower than England and Eastern averages. However, it is improving in recent years. And then under 75 mortality rate for circulatory diseases considered preventable in Luton is higher. And life expectancy for males and females remains lower than England and Eastern averages. And you will know that there's a big discrepancy within the town in terms of life expectancy as well. I've just also put we do need to increase social care indicators, I think, inside the JSNA, but as Jill's presentation earlier, this just confirms the increasing demand for adult social care in general. New requests for support have increased. The good news stories regarding health. Mothers in Luton that are known to be smokers at the time of delivery is lower than national regional averages. Aging well, emergency hospital admissions for falls and injuries in persons aged 65 and over in Luton is similar, but we have the lowest rate in our SITFA group. So this is one of the main statistical benchmarking groups that we use. And details of that group is in the full report at the front of the report. A rate of hip fractures for people over 65 in Luton is similar. Again, however, we have the lowest in our SITFA group. So these are authorities similar social demographic characteristics to Luton. So they face the same challenges as we do, or similar challenges, and we're the best in that group. So I thought I'd highlight it. An estimated dementia diagnosis rate for Luton is better than England and East of England averages, and we rank the best out of our SITFA group there. So some good news stories. Really quickly then, wider determinants, so non-health measures, but obviously these are all interconnected. Child poverty rates are down a little from the last report, but it's still obviously high at 39.4% and remains high compared to England and Eastern averages. Minimum income standard, we've already spoken about that in Jane's report, but again, there's been an increase. Living wage, number of people earning below is increasing, but still not as high as we'd liked it to be. Resident satisfaction, so this actually pertains to the 2023 residents survey. Resident satisfaction is the lowest in 6 years. So I thought I'd highlight that. Adults walking and cycling continues to fall. Average attainment 8 scores have gone down. So this is your GCSE averages have gone down for 2 consecutive years up to 2023. We don't have 2024 to report on yet. Obviously, the exams were done in the summer. We don't have that. So it's the 2 years up to 2023 that they've gone down. And just to bear in mind that actually there was what they call grade inflation in the COVID year. So 20 and 21, there's grade inflation due to assessments being done instead of examinations. And that happened across the board. Grades went up and they've come back down. So there's some of it coming back to expected levels. So just bear that in mind. Violence against the person. It was down in the year to date, but it has been continuously rising. So we'll just have to wait and see if that's a trend or if it carries on rising. Unemployment levels are up. People with no qualifications is up. Number of new dwellings completed as a percentage of total dwellings. So we're into the sort of housing issues now. Aren't as high as they should be really. And the housing affordability ratio, this is average earnings against average house prices, continues to widen. And it's the second worst in our SITFA group, Slough being higher than Luton for that one. And temporary accommodation is amongst the highest rates in the country. And then the better news stories for the wider determinants, emissions across the town are down across all sectors. So it's good news there. The airport has achieved, so this is London Luton Airport, the operating company has achieved level 4 for that particular award. It was at level 3, it's got to level 4. So again, a good story for the environment. We've got more electric vehicle charging points. In terms of rate against others, we're a bit behind benchmarks, but we're still adding to them. Fuel poverty levels are down. Most of our schools actually are good or outstanding. And a few more, the domestic violence is down. I have been told that we've got to take domestic violence coming down with a pinch of salt, because by the nature of domestic violence, it's not fully reported anyway, but it is down. GDP per head at the bottom there has improved for 2 consecutive years. So it's real bounce back in the economy, back to pre-pandemic levels. And just at the bottom there, the council staff, obviously we want to increase the people of minority backgrounds in the council staff and in management positions, and we've improved on that. So that's just by exception. If I pass back to Sally just to set up the next stage.
Thanks, Adam. And So there's one more slide. If you want to just go on to the next slide, Element, and I'll just cover that one off. So the purpose of the JSNA, as we've talked about, is to inform the health and wellbeing, population wellbeing strategy that we own as a partnership board. But it's also about having one version of the truth that people can refer to as where they get their data from, that it drives strategy, and we know what our priorities are and we know what we need to be doing. So part of coming here is just to make people aware of where things are going, what the data is showing, and then we're also taking it across to various other conversations to help challenge that thinking around, so are you using this in your work, and where are the deep dives that are needed? So some of the deep dives that we're looking at around drug and alcohol, we've done one already for family hubs to inform the direction of travel for that work, and other needs assessments in the future, and then have a wider conversation around linking back to the 2040 measures and thinking about the next stage. And then it'll be published on the Luton Observatory.
Okay.
So open up to questions or comments.
Okay. Thank you, Sally. Bassett?
I was going to say, I think the alarming figure about child and infant mortality higher than both region and national, is that a case of just a direct correlation because of the deprivation levels, or are there other social indicators that directly correlate with that?
So I don't know exactly what the answer is. There will be lots of related factors. Deprivation will be one of them. Imagine the breakdown of the population that we have in Luton will be a key factor, but we're actually doing a really in-depth piece of work on that across BLMK at the moment that I'm leading, actually linked to the Maternity Neonatal Service Strategic Board, where the BLMK-wide Population Health Intelligence Unit are looking at all the data around that. And it's going to be really interesting, actually, because we can link the data set. So any woman that's given birth across Bedfordshire, Luton, Milton Keynes, you can link back to her primary care data and look at all of the risk factors, and then look at how likely a poor outcome was to have either had obesity, smoking, deprivation, ethnicity data, all of that. So it's going to be a really good deep dive, which will come out with recommendations in the new year. So we're just working on that now. So it is alarming, you're right, and we're looking at why that is and seeing what we can do about it.
Okay. Yeah. Umi?
Thank you. So looking at this document, a lot of the issues, and you might have heard me say all this before because I kind of say the same thing all the time, a lot of the issues are lifestyle related. So even the issues that aren't lifestyle related are, like mortality, for example, and particularly around diet and physical activity. And for me, I think it's so important, if we want to achieve that Luton 2040 vision, is that we're taking a whole system council approach to tackling some of that. So particularly around physical activity, the fact, and I feel like I raise this quite a lot, the fact that our streets aren't walkable, the lights, because of cuts that we've had to make, things like lighting and maintenance of pavements isn't done to the extent that it was 10 years ago. And that means that people feel less safe to walk the streets. Cycling, for example, we have lots of new housing developments having lots of spaces for cycling, but the sort of road infrastructure, I know we're working on a local cycling and walking plan, but I do think we need to think about how radical we need to be in terms of, and also in terms of diet, for example, our licensing and planning, and how we allow so many takeaways across Luton, particularly around schools and things like that. And I know this is stuff that we're definitely working on, because we've discussed it so many times, and I know that progress is being made. But I think for me, in the midst of the budget cuts that we're having to make, and that the fact that sort of solving some of these issues is probably quite expensive, I don't know if we're looking forward to the fact that in 16 years' time, in 2040, how much we will save the NHS and the local authority and housing if people are active and they're able to work for longer and able to afford their own homes because they're in better environments, that sort of thing. So I guess it's more of a comment about how radical we should be in being more open to putting more into the prevention and the other areas that the council's working in, and not making this just a public health issue or an NHS issue. The other thing I just wanted to mention quickly was in terms of the data from the JSNO, I know we're comparing with our Sit for Neighbours and things like that, but there are parts of this where, looking at it, actually, I think the results would be even more negative if we looked at Luton's population and the demographics. So, for example, where we talk about obesity, we categorise obesity as BMI, overweight and obesity, and the fact that our levels are higher than our Fit for Neighbours and statistically East of England. But if we consider the fact that a lot of our population is Black or Asian, you'd consider that the mortality that comes with obesity at 23.5, I think it is, or something like that, rather than 25. And when you do things like this, and we're comparing with the East of England or the whole of England, those sorts of aspects aren't considered. And the fact that Luton is unique in how diverse it is. And if we looked at the data, and I think there's other areas in here where I had a read and I thought, actually, it's probably a lot worse than what the data is showing. I know we can't fix that because data is data and we have to have a benchmark to compare it against, and not to be all doom and gloom. I mean, I have been, but yeah, it's just interesting, something that I don't know if that can be looked at into making the data a little bit more accurate. But yeah, thanks.
Should I pick up on the last point?
Okay.
Yeah, this is why we use the SITFA counsellor, because the SITFA authorities are those, the SITFA, the Chartered Institute Public Finance Accountants. We've used that group for you, so they model against. So if you look at the authorities in the other 15 local authorities outside London, they won't use London authorities for that, but outside London, you're looking at councils that are similar to us in terms of ethnic minority populations. You've got your Bradford, Oldham, Leicester, so on and so forth. So we're comparing ourselves, and in terms of population, is adjusted for population differences. So we might have a smaller population than, say, Leicester, but the outcomes are adjusted for population differences. I don't know if that's the answer to your question.
Yeah, no, I know that. I understand that it's adjusted for population and we're looking at statistical neighbours. But I guess in terms of data as a whole, when you're comparing those areas like Luton to the whole of the East of England, does that make sense? It's not something you can fix. I'm just commenting that when you're comparing it, there's even more disparity because you're considering the fact that adverse health outcomes come at a different rate when you are from an ethnic minority background. That makes sense. I think it's just more so a comment, but yeah, thank you.
Thank you, Phil.
Yeah, I'm just concerned with the being able to influence decisions is getting worse. The satisfaction as a place to live is decreasing and becoming less positive about the future. Now, those are all subjective perceptions. And it's worrying because we got with the 2040 programme going on, the health equity, the Marmot Town, I would have hoped and expected that to be increasing. So that quite shocks me. And it comes back to this thing that I've said previously, which is it's about selling it, communication, marketing, and doing what we can to promote the positives of what is here now and what is down the line. Hopefully Luton will go up again next season and that'll help. But you know what I mean? It's about having that vision and promoting that vision. That should affect all of those three because they're perceptions. They're not facts. They're what people feel in their own minds. And good advertising and marketing and promotion, I would hope, could change that. And if you change that to positive views and improvements, then that becomes self-generating and self-perpetuating.
No, I think that's a very, very important point you've made there, Phil. Very important. Kachita?
I was just going to comment back on the physical activity. Actually, through COVID, we found that more people were actually walking, and we introduced the walking maps to actually get people to come out and be safe while they were walking. So through our health and physical activity, we actually found that more people were going out and walking, but it wasn't safe sometimes when people were walking. And also when you're looking at data, some of the data wasn't actually there for us to compare now. So what we're able to see now, we can't actually say, have we made an improvement or, were we better before? Because I've always been saying that we need data to compare, but we never, and sometimes it's not just about comparing data. If we actually look at some of the work that we've put in to make some of that prevention for people being more active, physically active, to do things, it's been that people through COVID that were staying at home, weren't able to do things, were actually going out and walking. but it just meant that they weren't walking safely. Maybe they weren't wearing the correct shoes. These sort of things came out, especially from our ethnic minority group. So you would see people walking, but not with the correct, uniform. You'd say, whatever, the right shoes, probably going in the slippers, having accidents. You did find that there was a lot more of that. So we did a lot of work through physical activity, trying to ensure that we had walking map, people knew where they were walking, where they could walk to. So there is sometimes work that's being done in the background, but you can't actually see that in the data that we provide here. So it's difficult to try to say that there isn't any work being done. There is work being done, but sometimes it's difficult to put it down as data on some of the work that we're actually doing.
You want to come back there, Sally?
Yeah, I will actually, if that's okay. Thank you. Yeah, and I think the physical activity strategy, the physical activity plans that we have is a good example, and Naomi's right that we are doing a lot in that space, and obviously the purpose of this isn't to reflect on all of that, but your point that a lot of these are interconnected is right. So through the physical activity strategy, one of the themes is around systems that encourage physical activity, so linking to the travel plan, linking to green spaces, linking to the built environment. So all of the conversations are there and the right connections are there. But I think the challenge around can we be more ambitious, or can we really challenge ourselves to be doing more in that space is a good one. But we definitely are doing a lot around physical activity, and it's one that does involve everybody, and it's linked into mental health and it's linked into healthcare services. So it is really important. And what's encouraging in a way around seeing those things in this JSNA that are areas of concern, I don't think there's one in there that we're not really focusing on as not just public health as a system. I think every one of those has a strategic plan or is part of somebody's work plan, or there's none that think, oh God, missed a trick there, that completely blind to that. So I think that is encouraging, and as I said, when we do the population wellbeing strategy 1 year, next year's review, there will be going through this with a bit of a fine-tooth comb to say, are we missing anything on any of this? Do we need to build that in even further into what we're trying to do? But I think it's all really helpful challenge.
Okay, are there any other comments? Yes, Steph.
They get a lot of clients have got no reasons funds. They go to the police, they get into trouble. They come to us, that information on so are we looking to sort of group more information, or are we just using one area of that data?
So the domestic violence one is reported crimes, and as Alan mentioned when he was presenting it, we are aware that any crime statistic, police crime statistic, is always going to be, it's only as good as the reporting allows it to be, and there will be some unreported. And we have a whole domestic abuse strategic plan and a deep dive needs assessment that's underway at the moment, actually, that will look at triangulating it a bit more and try and get a clearer picture, because the JSNA is those high level bits rather than the deep dive information. But if Nicola's actually the lead for domestic abuse, if she's not linked in some of that data that you get through, then we should include it in the needs assessment for domestic abuse. Yeah. And then the other question, do you want to answer that one?
So it's percentage of households in fuel poverty. That's from the Department of Business, Energy and Energy and Industrial Strategy. That is information from 2015 to 2022 was the time frame. So yeah.
So we do see that fluctuating. Other months, so we just want to know whether it's like season by season, a very different year by year.
Okay, thank you, Steph. Anybody else? No? No? Okay, we're just asked to note the JSNA. Are we happy to do that? Thank you very much.
Apologies, can I just make one final point? Just that all the data that we've got here is there's been a huge amount of work gone into this, and I think having it all in one place is really helpful. So I think if there's any suggestions, not now outside of the meeting, on where else we need to take this or how we make it more visible so people know about it, then they're really welcome.
Okay, please do get in touch if you've got ideas about where we can go. Thank you very much. Health Protection Annual Report. Is that yourself? Thank you.
Thank you, Chair. Hi, everybody. Christina Gleeson, Public Health Manager. This is my first time at the Health and Wellbeing Board, and it's also the first time we've actually brought a Health Protection Annual Report. So it is element 9 in the pack. I believe the councillors and elected members have received it, but I know there might have been some issues with the public facing pack, so we'll make sure that gets rectified following this meeting. So essentially the health protection is quite nice to actually follow the JSNA. So JSNA is a snapshot of the whole of public health, whilst health protection is one realm of public health. So we have 3 essential realms of public health: health protection, health services, health improvement. And by being able to do a report on just one realm, we are able to go deeper and look at some of those challenges, some of the successes, and actually give you some of the tangible examples within that report. So the plan is to provide an annual report to the Health and Wellbeing Board every year. It is health protection as a discipline is very specialised. It has a very particular set of skills, very particular set of agencies with responsibilities. Director of Public Health has a statutory responsibility for health protection, and it's as with all of public health, but particularly health protection, because of those specialisms, it's delivered in a collaborative format. So the report that has been circulated, my friend is Alman's going to share on the screen, so those of you who haven't seen it can just get a flavour of what it looks like. If we skip to the contents, it just gives you a flavour of all of the elements represented. So you have your ICB colleagues, you have emergency planning, you have UKHSA, you have drug and alcohol service, TB service, a whole raft of agencies and BCSE sector as well represented, because we do all have to work together to deliver this work. We're really keen to provide you with this continuous oversight. We're really acutely aware that during COVID you got quite regular updates around disease control, infection control, surveillance, management, detection, etc. And we wanted to kind of keep it on the agenda, but also not run the risk of people thinking that some of these infections, for example, are historic and gone and won't be around again. So one infection we're seeing a rise of both nationally, and we've had a local outbreak as well, as measles. So we, and I can talk a bit more about some of our challenges as I go through the report. But yeah, we're keen to provide you with that oversight, keen to adopt those learnings, have those specific behaviours that we did learn during COVID around infection control and the value of, following public health advice, public health information, health promotion, etc. And we don't want to lose those learnings. And then I suppose as a Marmot town, that health equity side of things, there's a lot of learnings that came out of COVID. We want to make sure they're not lost. There's a lot of learnings coming out of the COVID review that the government are doing. Again, we want to make sure that they are part of any work we do going forward. We want, as a health equity town, to showcase some of the work we're doing with our health inclusion groups and our underserved populations, and this report is able to show that around vaccinations, TB, etc., and also some challenges. This report is able to speak about Luton 2040 and how the realm of health protection links in with there. So, for example, child-friendly town, vaccine preventable diseases, very important for keeping our children well, preventing serious complications. So I referenced measles already. One serious complication of measles could be blindness. And it seems wholly unjust that from blindness or from a vaccine preventable disease, a child could end up blind in this day and age when it's avoidable. So we want people to be happy, healthy, live their lives free from the burden of preventable disease and infections. And then aging well, vaccines have a role in preventing and allows us to age well as well. And there's a new vaccine coming out, RSV, and it's keeping, again, that profile up for emerging considerations. And then just around that live well and the corporate values that Luton Council we have ourselves. So as part of our corporate values, we're very keen to be modelling best practice. So as a council, we actually offer an occupational health offer to all our staff for seasonal vaccinations. And just a plug, there was some in the work-life balance week last week. It was seasonal winter vaccines, but also we did MMR catch-ups, we did diphtheria, tetanus, polio, particularly for people who are out working in soil and potentially other materials which they could pick up infections from. And yeah, we're one of the most largest employers in the town, so having that workforce modelling is great. And we're able then to assure business continuity from as well. So if our staff are vaccinated, COVID-19, they ideally would get a less serious form of the infection. They would be more difficult to pass on, so less transmissible because of the infection. That keeps the council working and everything ticking over, and those vital services were already strapped. We don't want to add extra financial burden, so that business continuity is really important. And yeah, just to get you to flick to page 5 on the report, just to give you some of the priorities and emerging issues. So I spoke about measles already. So a third of the measles cases in the east of England were in Luton between the 1st of January this year and the 26th of August this year. Quite a startling response. This is outside London. We know London and Birmingham had significant increases, but we did in the east of England. It's not something we want to be topping the charts for. And we did have an outbreak in the town in a very vulnerable community. There was a system-led work, which is detailed in the report, which thankfully stopped that. We stopped it at 7 cases, and the community it occurred in all live in very close, tight-knit proximity. There is known vaccine hesitancy, known poor uptake of vaccines, so we were able to stop known contacts from contracting the disease. And although some of the children were very unwell, they have thankfully all made a full recovery. And within that community, it is brought it back to reality of this isn't a historic disease, and it is something that they need to consider. And we ran a catch-up vaccination programme within the community with our NHS colleagues, and we had a really great uptake. There was one family, we actually vaccinated 4 generations of that family because the mum of the young kids said, "You are not coming into my home, you're not looking after my kids unless you're vaccinated." And it's actually quite a matriarchal society, so that was immense. Like the value of that was immense. And we had Luton Irish Forum there as well, who were well known. The CEO came down and gave out vouchers to our matriarchs to say thank you very much. Without you, we couldn't have done this. And from that piece of work, we have additional pieces of work because we did find other health concerns as well while we were there, and we're working with colleagues on that. So just goes to show some of those day-to-day workings that we do, actually how far-reaching we are. Tuberculosis, not great reading. We're 3 times the UK average for that, but we are one of the few local authorities who take a proactive approach to TB, and we do a twice yearly screening for tuberculosis, and we provide an integrated model where not only do we screen for tuberculosis but also other infections which are common in the community alongside that. So for substance misuse, homelessness, people who experience homelessness, often we find high rates of sexual health disease, liver damage. We provide vaccinations for them as well. So that integrated model is one method that we're using to tackle tuberculosis, and we were successful in breaking quite a long enduring cluster on that. HPV, really successful vaccine, really bad reputation. Parts of our community feel that it encourages promiscuity in young people. They believe that, as a sexually transmitted disease, if you get a vaccine against a sexually transmitted disease, you're therefore increasing promiscuity. It is one method of contracting HPV, but primarily HPV vaccine is a cancer vaccine, and it's just getting that communication clear to parents. And actually, the vaccine is so successful that in Scotland, that's where the latest data is from. They've been able to cut rates hugely significantly, and the JCVI have now recommended that this vaccine is so good at what it does, it now only needs 1 dose, not 2. So all those things will help Luton and will help improve uptake, but this is your snapshot for the last year, but these are our 6 areas that we want to look for. Seasonal flu, quite timely time we're going into. Whooping cough, we haven't thankfully seen the cases in Luton as we have in England and elsewhere in the country, but we have been really proactive with our health partners in establishing a really robust system and putting together established networks. So our family hubs are promoting vaccinations. Our family hubs are supporting with the whole maternity cycle the whole way through. So we're using our existing infrastructure as well as looking at what new and innovative things we can do. So I would encourage you to have a read through the report. Would love to hear any feedback, but hopefully you'll see, yes, despite our challenges, there are actually some really good news stories, and a lot of it comes through in the case studies that are detailed in it. I've given you a flavour of them. But ultimately it just shows what an asset this town is with its community, and how everybody both comes together. And as I said, this is a collaborative report, so agencies have actually written their own report and we've collated it. So that's how much buy-in there is, that people will actually collate this, or I will collate this report, but our agencies will write it, and it's just to give you a flavour of, they may be frontline services and not get the oversight that maybe other areas get, but they work very hard. And this really does showcase their work in a tremendous, nice, accessible, colourful format. So I commend it to the
Thank you very much, and for a full explanation around the health protection annual report. And I apologise to any members who didn't get this before the meeting. We can make it available afterwards if you didn't get it. Are there any questions? No, it was quite a full report. You kind of, so I'm not surprised there weren't any questions. But yes, there is.
A question about the vaccine rate. Thank you for the in details report. I mean, I know you have a different location to offer the vaccination service, but how are you going to, do you have any plan to reach out to the community? Because, to encourage the people to send their children for vaccination, to make it more awareness and reach to the, the community level, or some sort of awareness or something like this. Do you have any plan? Because I think is vaccination level uptake is still low compared to Luton population. Is there anything you have a plan to reach out? Thank you.
So that's a really good question. So that's where where it's really useful, because the locations of a lot of clinics are in the community. So you have your community centres, you've Chall End, you've Luton Irish Forum, you have a Bury Park Community Centre. That's where we're using our established networks. We have our family hubs, Flying Start. So they're all community facing organisations, and they know their communities, and they amplify and relay our messages quite well. We also work very closely with our ICB colleagues, and we have boards and strategic planning, and we do a local communication as well. So we use the national assets for the likes of seasonal flu, but we also then develop local assets that represent Luton people, and we have in the past had senior leaders from Councillor Simmons has modelled for us in vaccinations. So we do. I think because we commission a lot of services, we tend to get into the community through that realm, but we have been upping our outreach offers, and we have been a bit more visible as a team, and I think that is paying dividends. More people are aware of what we do, but I completely take your point. It's very important that we're reaching into the communities that are seldom heard, and maybe not receiving the messages in the correct format, correct language, in an accessible manner. So we're doing a lot of work on that, but more could be done.
Okay, Umi.
Yeah, just to add to that, it's really concerning to think that a child in Luton could go blind because of something that's completely preventable. And I guess a lot of it will be from nationally. It's probably a bit of an issue where people don't have trust in vaccines since COVID, so we can't solve. But just adding on to the community stuff, how much are you going into schools? Because that's where you can access the young people, but you can also access their parents in dispelling some of the myths around vaccines and that sort of stuff.
Oh, absolutely. So that we have a community and school aged immunisations team, which are commissioned by NHS England, but we have a working group and we work with them to develop assets and develop communications. We have our family liaison partners within public health. So one of my colleagues, Neela, has a very complete network, and we take turns and we go and we represent and we bring up some of these concerns. When we had the measles situation, I was able to go and explain about it and actually give the context at the time as a live report. Schools, for example, are very good on reporting infections, and since COVID, they're very astute in what constitutes an outbreak, what they need to do, who they need to contact. And we have really strong, and so do care homes and many of the agencies who suffered during COVID. But we are definitely capitalising on that. And this is one of the main reasons having this report, because people can actually see the impact they're having as well. Because without the schools, without the community centres, we wouldn't have been able to deliver and showcase this report. So, definitely making use of all our assets in the town.
Okay, anybody else? Okay, I think we're asked just to note this report tonight. So thank you very much. Thank you very much for coming along. Thank you. The following three reports, 10, 11 and 12, are all retrospective approval reports. I think, did you say Kate was online? If you've got any questions on them, but I actually, due to the general election, the meetings were changed, etc. So I had to take decisions on this, and I'm asking you for retrospective approval. So that's item 10. Are there any questions on that report? Happy to approve it. Thank you. Item 11. Yeah, happy with that. And item 12. Thank you very much, everybody. Item 13 is the Health and Wellbeing Board draft work programme. Happy to take any questions on that or changes if anybody member has them at all. We're still kind of working on it, so it probably will be updated anyway. And item 14 is the future approach to meetings. Now, I changed the way we did it tonight. We had a conversation about residential care, which I think has come out with a programme for a summit and a way forward. And I'm wondering if you are interested in having other topics of that nature there that are challenging, not just for the council, but for health and other people. One springs to mind is housing. that I think everybody would probably welcome a discussion on that. So, and there are others, and if people have got ideas, to put them forward. But if you're okay with that, we'll plan each of the meetings with the introductory topic at the start. Is that okay with everyone? Okay, brilliant. And then the last items are all for information only. They're not anything. They're on blue pages for just for information. They're reports that have gone through the system. And we thought that we would do that with the information items, otherwise it gets confused as to which ones are for agreement and which ones are just for you to read. Is everyone okay with that as a way forward? Yeah? Sorry.
Yeah, I'm perfectly happy with that, Hazel. I just think maybe we just need to give a little bit more thought about people joining the meeting, thinking that they may get asked questions, because it's obviously quite late and people.
I agree. We did decide, didn't we, that they could all go online, so that they didn't have to travel here, because and I accept that. But yeah, we'll have a look at that. Definitely. Yeah. We'll have a look at that. Are there any other questions? Yes.
Yeah, I was just going to say, if we can, in the future agendas, make it clear which ones are just for noting, which ones are for discussion and stuff, because I couldn't work it out from looking at this.
Okay.
Thank you.
Okay. Yeah, take that one. Any other things you'd like us to do in a better way? Yes, Sally.
Just a couple of points. One is just that the last item, the BCF item, there are some slides that Kate's just sent me a message to say she can circulate afterwards, because the paper itself was quite dense and the slides just summarise it just for cover. And the other point I was just going to make, following on from Umi's actually, was I think that because we do tend to have on the items that come through quite a helpful discussion anyway, I think we probably haven't quite got it right in terms of the difference that item had. I don't know how Jill felt, but we still sort of have lots of questions in discussion for the other items as well. So I don't think it felt sizably different to the other two items really. Okay. But maybe we just need to work on that a little bit more around it being we're shaping something going forward. Because the other ones are not the health protection annual report, but often we'll bring something that's, we're shaping and thinking about it as well, and it doesn't feel hugely different. I don't know.
I think you're right to an extent, Sally. We've all got to get in the rhythm of doing it a little bit differently. But I think the difference for me bringing that report was it didn't set out at all what we're going to do about it. It was all left open purposefully to have that discussion so that all the members of the Health and Wellbeing Board can help shape that thought and also support us to get that conversation going in other arenas. So I think for me that was really useful. But there were a lot of questions just directed at me, and that way it felt quite similar, and maybe it's just us all getting used to really kind of thinking together about what we can do.
It was a different way of doing things, but I think for me, I want it to be a working committee, that it does something, that you don't just nod through reports, which is how it felt before. And I think that if you want to influence change and changing people's lives, it's better. We've all got a contribution to make. So the more people that take part in it, I think is better. So, yes.
I keep asking. So the two items then, 15 and 16, were you expecting to present and get comments from people, or
the BCF ones?
Yeah.
No, those ones there were some slides that we were going to go through, but it's quite information sharing, and as Hazel said, it's retrospective, so it is a bit of a way through that one. But I think the BCF reports are quite unusual in how they come here, is that really tight governance, but other things are much more.
The general election, wasn't it, that caused it?
Yeah, no, I just meant because you said you had some slides, so
yes.
Okay.
Are we okay then? I'm sorry.
Sorry, just one more thing. Thinking about, because I brought some slides to set the context. I think it might be helpful. I'm assuming that it might be helpful in future for members of this board to receive those slides in advance. Not that we wouldn't present it, but give people a chance to think about the kind of questions or thoughts that they might have in advance.
I think
it's hard to do it all after.
I think that will be useful. Yeah. Yes, Nikki.
I just had one AOB I wanted to plug. It's called the NHS app. So ELF have been fantastic, and Health Watch on Friday we did something. So, for example, if any of you would like to have a go and being sort of what I call champions, download. On there, we can talk you through 100%. You can book your flu and COVID vaccinations with pharmacists via your NHS app. I've gone through it. So we want to be really clear about where it's helpful. And we are getting some languages. So the medical director, not the medical director, the national director for it. So if anyone's interested, we're doing a number of little sessions, and we'll make sure I do it through Maria so that people can pick up. So we all need to help to guide the national team how we make it better and better, but it does pick up all the issues we've raised about having one point of
contact,
access, so it will get better and better.
It'll get better, won't it, gradually? Hopefully. Okay, thank you everybody for your and thank the members of the public that have come along tonight. Thank you very much for coming.